the authors envisioned a system that automatically pulls the patient data at admission and runs a prediction and delivers a risk estimate to the clinicians in real time. This dashboard displays the risks for post-op complication with larger red area indicating the higher post-op risks. The model performed excellently in all post-op complications, and in a follow-up study, the model outperformed the clinician's assessment. In the subsequent study, the team examined how incorporating intraoperative time series data into the preoperative model affected the model's predictive performance. In another follow-up work, this model was impressively prospectively validated on more than 20,000 surgical cases and showing strong predictive performance. The authors also developed a mobile application allowing clinicians to monitor real-time risk on their phones. The second example is the UPMC risk prediction model. This is fully automated preoperative machine learning model that was externally validated and prospectively validated. It used only preoperative EHR variables, and the performance was excellent with the AURC of 0.95. This model also provides interpretability through SHAP analysis. Additionally, when compared to the ACS NSQIP surgical risk calculator, this model shows superior performance. And this model is now fully deployed in clinical practice. So every morning at 8 a.m., it generates a risk estimate for all surgeries without any manual data extraction. This system also flagged the top 10% of patients as highest risk, so enabling clinicians to plan perioperative management and resource allocation. This highlights that the accurate and automated risk prediction truly matters in real-world clinical workflows. Now let's move on to the next part, the multimodal deep learning model. ECG contains a rich amount of physiologic information, so they are inexpensive and non-invasive and used as a routine monitor in most surgical cases. So many studies have explored using preoperative ECGs for risk prediction. However, traditionally, ECGs were often oversimplified into two binary findings, such as normal versus abnormal, so which limited their clinical utility and resulted in inconsistent performance. With the recent advances in deep learning, we can now directly analyze raw ECG waveforms. Among the most well-known studies applying deep learning to ECGs, these two landmark articles for arrhythmia detection. On the left side, the Andrews team showed that the deep neural network using single-lead ECG from wearable patch could achieve cardiologist-level arrhythmia detection. On the right side, the model analyzing only just 10-second 12-lead ECGs was able to predict atrial fibrillation even when ECG showed normal sinus rhythm. These examples demonstrate how deep learning can capture subtle electrical signatures far beyond the human interpretation. One representative example is this model is called PreOpNet.